Hi, good afternoon, everyone. My name is Dr. Saleh. I'm a pain management physician at OrthoVirginia. I practice at our Lynchburg office. My background, I did training in physical medicine and rehabilitation in New York. And then I moved out to do a pain management fellowship at ECU, Richmond, Virginia. Today, I wanted to talk to you about a topic that's pretty common for a lower back pain. It's called facet. It's a very common condition that we see every day in our clinic concerning patients with chronic low back pain. So low back pain in general is one of the most common reasons for emergency department visits and all primary care doctor visits. It always comes into the top 5 reasons for doctors' visits. It has a huge impact on workday losses. It's the leading cause of workday losses across the whole nation. So it has a huge economical impact on a personal level and a national level as well. The incidence of low back pain is very common. 84% of adults will experience low back pain at least once in their lifetime. So it's very prevalent. However, the good news is that in a lot of cases, 90% of patients, the condition will resolve within the first 6 to 12 weeks. Whether with or without treatment, most patients will get better in the first 12 weeks. And usually the treatment during that time is to kind of ease their pain, make it tolerated better. Unfortunately, still the rate of recovery is pretty high. So 80% will have the same back pain episode recur within 1 to 2 years of their first episode of back pain. Well, there are many common causes of low back pain, whether it's acute back pain or chronic low back pain. There are simple causes of low back pain like muscle strain, which is a simple muscle tear. Of course, a lot of patients will have degenerative disc disease, which is wear and tear in the disc, which is the cushion in between the vertebrae and our spine. Facet, which is wear and tear in the joints of the lower back, and we'll talk more about that in more details later on in this presentation. And there's the big joints connecting the spine to the pelvis called the sacroiliac joint, or SI joint for short. And those could be also a cause of chronic low back pain. Then we have some nerve conditions like spinal stenosis, like narrowing of the main canal of the spine that can cause lower back pain. And then for trauma patient or elderly patient, they can have compression fractures, which is another cause of low back pain. And when I see somebody in my clinic for acute or chronic low back pain, the first thing we want to differentiate is if their pain is localized to their lower back or does it radiate down to their leg. And the thing that we're mostly interested in, if it's mostly radiating down below their knee, extending all the way down to their calf or down to their foot and toes. And if they have any kind of nerve pain characteristics like tingling, numbness, or cramping in their legs. So if we identify that the patient has nerve pain and pain extending down to their legs, that's when we start to do workup to see if they have nerve or impingement at their back. If their back pain is localized, we think it's more caused by a mechanical issue for the most part, whether it's joint or muscle pain. Now, acute low back pain is pain that has not been extending beyond 6 months. So it's pain that's not 6 months. And again, as I mentioned, a lot of this pain can still get better within the first 12 weeks. Usually, treatment at that point will include some mild analgesics, some muscle relaxants. And again, we incorporate physical therapy and gradually retard the return back to activity. So for chronic low back pain that's basically has extended beyond 6 months, which happens in a much smaller group of our population. So about 8% of our population will deal with chronic low back pain symptoms. Unfortunately, it can affect adults of all age groups. So we see patients as young as 18 years old, patients definitely are elderly or are experiencing chronic low back pain. So talking a little bit about the anatomy of the spine has a little bit more complex anatomy compared to the rest of our joints in our body. So what is included in the spine that's not included in a lot of other parts of our body are the nerves being an integral part of the spine itself. But we can still think of the lumbar spine, the lower back, which is what we're talking about today, as the 5 vertebral bodies that we have in there, numbering from top to bottom, 1 to 5. Now, when bones come in contact, they form joints. So if you look at this picture in here, there are discs in between the vertebral bodies up front, and discs are a form of the joint that connects the bodies of the spine. In the back part of the spine, the posterior aspect of the spine, that's what we're concentrating on today. And you can see these arrows kind of pointing at the facet joints, which we'll be talking about later on in more details. But these facet joints basically connect the spine and the back part of the spine. And basically, the joints are on either side of the spine. The facet extends from the top part of the spine, from the cervical spine all the way down to our waistline. Now, the vertebral bodies and the lumbar spine are the one that have the proper numbers. So we have lumbar spine 1 all the way down to 5. The discs and the facet joints don't have the proper numbers. They have the interval numbers. So if you ever looked at an MRI report, we'll see that the discs are described as the L4-L5 disc. Now, the facet joints are similar to the discs. They have these interval numbers. They have the L4-5 and the L5-S1. So every facet joint are numbered, and they don't have a single number to identify them. And we also have the facet joints on both sides of the spine. So we have right and left facet joint. Now, in order to see the facet joint in more detail, we have to kind of turn the spine to kind of like a 45-degree angle to open up the facet joints in the lower back. And again, as you can see, the arrows over there are pointing at the facet joints on the left side of the spine, the last two facet joints there. The top one is called the L4-5 and the bottom one is the L5-S1. And that's how the joints are oriented in our lower back. On the x-rays, we look at AP views, the one on the left, which is a frontal view, and we want to look at the alignment of the spine. Now, when it comes to the facet joints, we can't see them too well on the AP view, so we look at lateral views, and you can see the arrows on the right side. Those are pointing at the last two facet joints in our lumbar spine. This x-ray is for a normal patient, so there are no arthritis or wear and tear on those joints, so they look like they are normal joints. So when I see somebody in my clinic and I identify them as they possibly might have pain from their facet joints, the most common things that I'm looking at, first of all, is their pain. Localized, or is it radiating pain? Now, if the pain is radiating below the knee, I suspect that this is more of a nerve condition, like what the patient would call sciatica or a nerve root impingement. But if their pain is localized to their back and extending maybe to the posterior aspect of their thigh, that could be very much pain from their facet joint. Usually pain from the facet joint is something that gets worse with activity. And I know that any pain can sound like it can get better or worse with activity, but specifically for facet joints, we're looking at pain that gets worse when patients first get out of bed in the morning, they feel like their back is stiff. And then when they do activities like standing at a kitchen countertop, or they're washing the dishes or cooking something or brushing their teeth, that they have this increased back pain. And sometimes this pain kind of gets a little bit better as the day goes by initially, but then as they continue during their activities during the day, they have more increased pain as the day goes by. Now on exam, mostly you want to see if they're having pain with flexion or extension. If they're bending forward, that's flexion. Usually that kind of makes their pain a little bit better on exam. And then if they have more pain while they're extending their back, or more specifically, if they are rotating their spine and extending their back, and that causes more pain, that's usually pain related to facet joints. Now, there is no great imaging studies that tells us that the pain is arising or coming from a facet joint. There is very poor correlation between pain from the facet joint and imaging studies. You can have x-rays or CAT scans or MRIs that show you that there is no arthritis or no wear and tear in the facet joints, but there could still be pain from the facet joint. And vice versa, of course. You can have significant arthritis or wear and tear on those joints on the MRI or CT scans, and the patient might not be experiencing any pain still. So what do we do if we identify that somebody has pain from their facet joints and their lower back? Now, first of all, we always start with conservative measures. So we can start with mild analgesics like NSAIDs and muscle relaxants. And we always emphasize the importance of physical therapy. But we have good evidence that strengthening the core muscles can help significantly with localized lower back pain. But let's say we went through those treatment options. Basically, we tried the medications, we tried the core muscle strengthening and physical therapy, and we haven't had good results. That's when we move on to the spine interventions or spine injections. So the first spine injection that we do for the facet joints are called the medial branch block. Now, if you look at the diagram on the right side over here, there are arrows pointing to these small nerves. And these are nerves going to the facet joint. So basically, when the facet joint is causing pain, that signal of pain is carried by that small nerve called the medial branch up to our brain. So it relays that signal from the joint to our brain to let us know that there is pain coming from that joint. So in order for us to identify if the joint is painful or not, we do what we call medial branch blocks. So basically, under x-ray or fluoroscopy, we have the patient come into the injection suite, and then we target those nerves that are taking that signal of pain from the joint up to our brain, and we block them using a local anesthetic. Now remember, this is only a diagnostic injection. It's only a test. It's not going to treat the problem, but it gives us a better understanding of what's causing the pain. So we block those nerves, and we have to block at least 2 nerves in a row. And that's because each one of those joints are innervated by 2 nerves. So in order to block just one joint, we have to actually block 2 nerves. And typically, because we have arthritis or pain coming from the facet joints on both sides of the lower back, we do these injections on both sides, and we usually do them at least 3 levels to block 2 joints on the lower back on either side. And what I do after these injections, I ask my patients to go home and do the activities that causes their pain, whether it's standing, walking, gardening, whatever it is that actually causes the pain. Because again, this is an injection that's only testing if the pain is coming from the joint or not. So if they go home and they try to do the activities that usually kind of causes their pain, and their pain is a lot better after the block, the local anesthetic block, that means that their pain is coming from this joint. Now, unfortunately, the effects of these blocks are temporary. So basically, the local anesthetic works for a few hours. You feel pain relief for a few hours. That means that the pain is coming from the facet joint. And unfortunately, the patient usually experiencing the pain coming back again within 2 or 3 days after the injection. We had to do these injections twice to confirm that the patient is having pain from those joints. And if that happens, then we move on to the next step, which is called radiofrequency ablation. So the radiofrequency ablation basically is a technology where we convert the radio waves from a machine that's introduced into our bodies next to those nerves that we are targeting, the ones that are innervating the facet joints. And basically, it creates a small lesions to those nerves, the medial branches. So basically, we stop the function of that nerve. So basically, we stop feeling the joints of our lower back. And we usually do it again at the same levels that we did the initial block to figure out which levels, which side is the pain is coming. So again, typically we do it on 3 levels on both sides of the lower back. In here, the diagram on the right side shows you where the needles will be placed at, and they are placed right next to the nerve that we are targeting. On the left side in there, this is the shape of the needle. Basically, the needle is insulated except for the last 10 millimeters of the needle tip, which is the only part that heats up and actually causes the lesion of that nerve. And again, we have good studies that if we identify that the pain is coming from the facet joint, and we move on to do the initial blocks, we get good results with that. That if we do the radiofrequency ablation at that point, again, sometimes we call it cauterization of the nerves, that there's good evidence that it can reduce pain sickness for about a year or maybe a little longer than that. Now, after we do the lumbar radiofrequency ablation or cauterization of the nerve, sometimes the pain symptoms can reduce significantly within the first week or 2. Sometimes it takes up to 4 to 6 weeks for the best results after the nerve ablation. Generally, we emphasize the importance of doing core muscle exercises after that, because at that point, usually the pain is a lot better and we can actually strengthen our core muscles a lot longer and better than without the radiofrequency ablation. And if their patients are on G6 or pain medications, we're trying to wean them down on those medications. You can't take a break from that. Unfortunately, those nerves can regrow again and have that repeated pain from the facet joints after 12 to 18 months. That's how long it takes for the nerve to regenerate. And at that point, if we identify that the pain is similar to what it was before we did the radiofrequency ablation, we can just go ahead and repeat the last part of the treatment, which is the radiofrequency ablation again. Sometimes we have to repeat it 2 or 3 times, and at some point, sometimes the nerve does not regrow again, and we don't have to repeat the procedure anymore. I included this picture because a lot of times patients don't know what to expect when they come to have spine interventions. Most of these procedures are done under local anesthetic, so there's no sedation involved. So patients come into the injection suite, they lie down at a table, face down on their belly, and we have this x-ray machine behind their back that's called a C-arm or fluoroscopy machine, where basically it gives us an x-ray picture so we can identify the areas we're targeting. And on the right will be a monitor where we're looking possibly under the x-ray to see the anatomy of the spine at the areas we are targeting that day. In summary, low back pain is very common. A good amount of our population would get low back pain at least one time in their life. However, there's good news that most of this will resolve within a few weeks. Again, whether it's on or with some medication management. Unfortunately, again, recurrence is pretty high. When it comes to chronic low back pain, there are multiple factors. Again, remember today we're only discussing one factor, which is the small joints of the lower back called facet joints. They are a pretty common cause of lower back pain. We always start with conservative measures if they have not been tried before, because we have good success with conservative measures for treating facet arthropathy and different conditions of the lower back. If that doesn't help enough, we move on to spine injections and interventions, which we talked about. And then at the end, we emphasize the importance of core muscle strength. Okay, any questions?
Thank you so much. So we will be answering questions submitted earlier and questions submitted live. Not all questions will be able to be answered, but we'll get through as many as we can in the time that we have. Our first question is, how can you tell if your pain is skeletal or muscular?
Now, first of all, when I see somebody in clinic and I'm wondering what's the cause of their pain, I'm trying to identify, first of all, where's the location of their pain. Again, if they have any pain that's radiated down to their legs, especially extending down below the knee, I think that's more nerve pain. Now, there is not much difference that we can tell if the patient has skeletal or muscular pain just from the location of their pain segments, because both of them can give you just localized lower back. That's when you're going to move on to maybe some imaging to look if you have any disc conditions that I think is causing any pain, and they're fine. Usually muscular pain is something that you will identify once you rule out all other causes. So basically, you've looked at the eye, you don't see any skeletal deformities or any pathologies or any problems in the spine that could be causing pain. Maybe even after doing the initial injections, the test injections for the facet joints, and you don't get the results you're expecting from the facet joint, maybe at that point you would say their pain is muscular. But usually what we try to differentiate in the spine is more, is it mechanical pain, is it joint and muscle pain, or is it nerve pain? We don't have so much this distinction between skeletal and muscular.
Thank you. Is chronic pain a result of previous injuries exacerbated by old age?
Well, the answer to both parts of this question is true. So yes, back pain could be caused by previous injury. We know that injuries can accelerate like some deterioration and degeneration of the spine, facet joint included, plus deterioration of the discs as well. But also as we age, our spine, the health of our joints basically tends to deteriorate, and that can cause some of these joint conditions and pain conditions that we described. So both parts of this can be at.
How old is too old for these treatments?
Well, the good thing about doing spine interventions, a lot of it is done under local anesthetics. So we don't use any anesthesia or deep sedation. That makes it a little bit more worried if patient has any like general health conditions that are not good or suitable for them to undergo surgeries. When it comes to spine interventions, doing facet joint injections, whether it's medial branches or radiofrequency ablation, there's no age limit. And I had patients in their 90s and we can still do these treatments. There are very little contraindications to doing these interventions in the spine. Mostly has to do with like history of previous back surgeries with hardware in the spine, where it becomes a little bit more difficult to do these.
Thank you. What is the next step if the medial branch block or the radiofrequency ablation don't stop the pain?
That's a good question. So if we did a medial and branch blocks and it did not help the pain as much as we were expecting, and it has to give patients quite significant amount of pain relief, they have to feel like almost back to normal before we actually proceed to the radiofrequency ablation. So usually we would not proceed to the radiofrequency ablation if the medial branch blocks did not help. Well, let's say we did the medial branch blocks and it helped, and we moved on to do the radiofrequency ablation and it did not help. At that point, we'll be looking back again to kind of the drawing board to see what are the other possible causes of the patient's pain symptoms. Because at that point, we have kind of eliminated at least the facet joint as being a source of pain. Now we have to look for other reasons. So now maybe we go back into the MRI. Do we see any disc degeneration that might be causing some inflammation in the end place of the bone? To see why they have this localized back pain. Do they have this bulge causing spinocytosis? Or they have other joints that are causing their pain, like the SI joint. Again, these are big sources of pain symptoms. Or they have muscular pain. That is not something that we can easily identify on.
Thank you. If the radiofrequency ablation helps, but the nerves regrow afterwards, how many times can you redo the radiofrequency ablation?
Well, there is no specific limit on how many times you can repeat the radiofrequency ablation. You can keep doing the radiofrequency ablation as long as they're working and as long as we think the pain is still coming from the facet joints. Now, it gets a little bit tricky after you do the radiofrequency ablation 2 or 3 times. And the reason for that is because when we're doing these procedures, we're doing them under X-ray. And technically, we don't see the nerve that we actually cauterized. We're only going after it anatomically. We know it's lying in a specific groove in the spine, and that's where we're going after. The problem when you create this kind of small lesion, you're basically creating a scar tissue that sometimes the nerve kind of finds a different path for it to grow around that scar tissue. But again, remember, we can't see the nerve, so we're going after the same target in the spine. So over a period of time, if you had like 3 or 4 radiofrequency ablation with our traditional method of doing the radiofrequency ablation, it might become less effective. Now, at that point, we have different machines that can create a bigger lesion than the traditional radiofrequency ablation to try to capture that nerve, even if the nerve is kind of wrapping around that scar tissue that we've been creating over the last few times. But this is a problem that we don't see too often. But there are machines that basically also do radiofrequency ablation, but basically they create a bigger lesion in that area so it can capture the nerve even like more efficiently, even if the nerve deviates to other paths.
Thank you. Is lower back pain related to osteoporosis?
Well, osteoporosis can give lower back pain, but usually that's not something that we see in our clinics every day. What we typically see is someone who has osteoporosis and has like a minor injury or trauma, and it doesn't require too much to develop a compression fracture in the spine from osteoporosis. So I had patients who basically were trying to make their bed in the morning, and because their bones are so soft, they tend to collapse on their own without any significant trauma. And that's usually what we end up seeing in our clinic as a result of osteoporosis. And usually the best treatment of osteoporosis is prevention. So we better have our patients get checked and do bone density scans once they reach the image when they need to get it checked, and treat osteoporosis before it happens. Because once it happens, there is high chance of fractures, and we see that quite often in the spine.
You mentioned strengthening lower back muscles can help eliminate chronic back pain. What exercises or types of exercises do you recommend?
Well, we see it again when we're treating like facet joint pain initially, before we start doing any spine interventions, that we try to do some conservative measures for those patients. And the conservative measures will include quite a bit of physical therapy, which is mostly for core muscle strengthening and leg muscle strengthening. So specifically strengthening the muscles of the lower back, the back extensor muscles, that's what can give us significant amount of pain relief. However, that's not always the case in everybody. Some patients have done physical therapy, they have been diligent with doing their home exercises on a daily basis, but they still cannot get enough relief from their facet joints by strengthening their muscles. But after we do the radiofrequency ablation, a lot of times we still emphasize strengthening their back muscles, so not to rely so much on the facet joints of the lower back. So mostly we're working on core muscle strengthening, especially the back extensor.
If someone has some pain, but the pain isn't too extreme, are they creating damage in their back or to their nerves by not getting it treated immediately?
Not really. I think all the procedures that we do in our spine, even including treatments like physical therapy and core muscle strengthening, cannot slow down degeneration. So I think degeneration happens on its own. We don't have any significant tools to slow down that degeneration. So I tell our patients just, again, live your life, do the activities that you want to do in your day, but definitely try to dedicate some time to strengthen your core muscle. And if the pain becomes uncomfortable, and again, pain is very subjective. So somebody might find like just standing, again, fixing something in their home or gardening that the pain is too uncomfortable, unbearable. That's when I tell them that we should treat it. But even if I see a lot of arthritis on the x-ray, but the patient is comfortable, they can do their activities every day without significant pain, or maybe they take a Tylenol or something and it helps with their pain symptom, I don't think that we should intervene in that.
Is there a scenario for doing both steroid injections and radiofrequency ablation at the same time?
I think this question, maybe let me rephrase it again. Steroid injections is something that's very general. People can get, or patients can get steroid injections in clinic without even like under x-ray. We can give a muscle steroid injection. there will be no role in giving a steroid injection in the muscle and doing radiofrequency ablation at the same time. Now, when we do radiofrequency ablation, most of us who do these procedures will inject steroid in the same location where we're actually doing the radiofrequency ablation. And the reason for that is because when we're creating this lesion where we want to cauterize that nerve, we're actually kind of inducing a little bit of more pain in that area and a little bit more inflammation by causing that lesion. So typically we would inject a little bit of steroid in that area while we're doing the radiofrequency ablation. So we actually inject steroids with radiofrequency ablation. However, the steroid is not the treatment. The steroid is just meant to decrease the amount of inflammation you might feel after the radiofrequency ablation.
Why is lower back pain so much worse at night when lying down than during the day when up and about?
I mean, that's a complicated question to answer because low back pain that's localized in the lower back, that's coming from mechanical problems like joint and muscles, usually that gets better actually at nighttime or if someone is laying down on a sofa or not doing much activities. That's the pain we've been discussing today from the facet joint or any mechanical pain for that sake. Now, mostly when patients are moving around in bed at night and they have facet joint pain, that's when their pain gets worse. Now, if we compare this to pain from a pinched nerve or sciatica pain that's going down the leg, that is usually the pain that gets worse at nighttime. Now, there are some conditions that gives you localized back pain that gets worse with nighttime. Not a lot of conditions, but one of them could be disc pain. If you have pain from the disc itself, which is not a very well understood concept in the spine. When is a disc painful without bulging? But there are conditions where there is disc pain or disc inflammation in the end plates in the bones above and below the disc that can get a little bit worse at nighttime. So there's no one specific answer for that. But my first way of trying to understand this is asking if there's pain associated with that lower back in at night if it's going down to the leg. And if that's the case, then that's more nerve pain. And that's actually quite common.
Thank you so much. That is all the time that we have for today. Dr. Saleh, would you like to close?
Well, thank you so much, everyone, for showing up. I hope this session was informative and helpful. If you have any further questions, I'd be more than happy to answer them later on.